when I was in psychiatry, when I got into psychiatry, actually I was a neurologist and got into psychiatry by accident, but anyhow, the dominant theory was psychoanalytic theory, and almost all of the psychotherapists in those days were doctors. So after I did my psychoanalytic training, I wanted to do some research. I wanted to test out the hypothesis that depression is caused by inverted hostility. The individual is angry at somebody else and then turns the anger against the self. And this is then represented in a need to suffer. And it makes really good sense that you see the need to suffer in everything that the depressive feels and does. They don't have any pleasure. They're very self-critical themselves. They'll even commit suicide. They will do things that are counterproductive. And indeed, it seems that self-suffering, or the need to suffer. And so I tested that out in an experiment. I got the dreams of depressed patients, and indeed the dreams showed that the patient was portrayed as a loser, things were bad happening, and again, it seemed to all have to do with the need to suffer. And so I actually wrote a paper that came out in Psychosomatic Medicine. It talked about masochistic dreams in depressed patients. Then I tested it out. And so we did a couple of experiments. One is, if these individuals have a need to suffer, then if you put them in an experimental paradigm where they're going to have a choice between choosing particular words that are being punished or approved of by the therapist as compared to normals. And it turned out that they would selectively extract words that were being approved of, so that they were not doing something that would make them suffer, but they were doing something that would make them feel better. Then I did a card sorting task, and we had normals and we had depressed patients. And the depressed patients, it was worked out the depressed patients would either succeed or fail on this particular task, as would the normals. Turned out that the depressed patients did very well after success. So they weren't punishing themselves. They were seeking positive outcomes if they could. And whereas, it's just interestingly, the normals did better after failure. And when I wrote the paper, my final line was for depressed patients, nothing succeeds like success, and for non-depressed patients, nothing succeeds like failure. Anyhow, so this was the experimental aspect that shifted my mind away from the original hypothesis. And then I went back and I was able to see for myself then that the themes in the dreams were exactly the same themes that the patient had in their waking life, and that they were distorting situations according to this belief that they had as being losers and inadequate and ineffective and unlovable. And so it was this belief in themselves, this belief that they carried on about themselves, that then led to misinterpretations of reality. And when we change the misinterpretations by looking for the evidence, seeing whether it's logical, looking for alternative explanations and so on, then they got better. And as I've mentioned many times, Judy's heard me say this, after 10 or 12 visits after I was doing this, my practice shrunk, because the patients would say, Dr. Beck, you've helped me a lot, but it's time to say goodbye.